Hello there. My name is Dr. Kayla Gritzmacher, and today I'm going to be going over my presentation that I had put together for my dissertation defense back in March of 2024, which was successful, going over my recent research on the effects of nurse burnout on patient fall rates in long-term care. This is the direct presentation that I did use, and I just wanted to come back to it now after the fact and put together something I can share with the community so that they can watch it and share it with others to kind of spread the word of what my research was as we continue to learn more about burnout and as I continue to further my research on it within the healthcare community. So we will begin. First and foremost, why burnout? Why did I choose burnout for my topic? My background is nurse. I am a nurse by background. I have my master's in nursing. I've worked in healthcare field since 15, so I've been in it a long time. And burnout has become a global crisis. It's a term that we have heard a lot about in recent years, really, especially during that COVID-19 pandemic. I was actively working during the pandemic as a nursing director in a subacute rehab, and I felt the effects of it. My staff were feeling the effects of it. So that kind of really sparked my interest in researching this more, as it is something that I hold extremely dear to myself because I have been there, and I think it deserves the increased conversations about it. So to really first understand burnout, though, we need to know and communicate what the definition of it is, which is a prolonged psychological reaction to chronic emotional and interpersonal stressors on the job. Burnout is applicable in any working setting. However, healthcare workers are at a higher risk of experiencing burnout. More than 50% of healthcare clinicians within the United States do experience burnout symptoms. These can be influenced by physical, social, and psychological factors that are present in a nurse's work environment. The nurse's work environment is one of the causes and factors that goes into the creation of burnout. Burnout, it can really have a real negative effect on patient care and outcomes. So it's not just affecting the employee, the healthcare worker, it's really affecting the patients that we're caring for. It has been shown to have decreased patient satisfaction, increased risk of medical errors, increased risk of falls, infections, pressure injuries, all those critical patient outcomes that we're looking at and dealing with on a day-to-day basis as a nurse. Adverse patient events are one of the 10 leading causes of death and disability in the world, according to the World Health Organization. And patient safety, as we all know, is the focus of many organizations for their continuous improvement plans, analysis of the quality of care being delivered, and adequate policy development. Nurses are at the core of patient care delivery. They make all the crucial efforts to improve the quality of patient care and the patient's quality of life. And patient care delivery has been shown to be negatively impacted when nurses are more burned out. And then in 2019, we saw that global pandemic of the coronavirus 19 happen. This pandemic quickly became very deadly, and we saw it impact many aspects of all of the healthcare providers' work environments and workplace stressors. This has then in turn increased that risk of providers developing burnout, with nurses verbalizing that they are more fearful of committing medical errors due to their increased exhaustion and burnout levels. So with that, researching and furthering the discussion on burnout and how it impacts patient care and the individuals providing that care is critical to improving the current state of healthcare delivery, while also informing the healthcare industry on how to approach and improve that patient care. So the gap in research. When I was completing the comprehensive literature review for my study, I did recognize there was a great amount of research being done on burnout in healthcare. However, a lot of that research is being done in the hospital setting and has not been done in the long-term care sector. I also found that a majority of the research is regarding the nurses' perceptions of their burnout and the implications that it has on patient care delivery and patient outcomes, but there really hasn't been a lot of research analyzing that objective patient data, the hard data. So I had chose to pursue that route, and I used what you see over here in figure 1 as the nursing. This is the expanded nursing work-life model, but it is based off of I expanded it a little bit in that purple area over to the right, but it is the nursing work-life model. I use this as the guide to complete my research. It was originally developed in 2006 by Leader and Laschinger, and it was based upon Eileen Lake's 2002 practice environment scale of the Nursing Work Index. The Nursing Work Index scale by Eileen Lake was created for use within the Magnet Hospital system to identify hospitals that effectively support high-quality professional nursing practice. And Laschinger and Leader really wanted to further understand burnout and its influences on nurses while also providing an understanding of how professional nursing practice characteristics are interlinked with burnout. So that is where this new figure came to life. As you can see, there are 3 aspects of that. There's the nursing work environment, which includes strong leadership, the R&MD collaboration, policy involvement, staffing adequacy, and the nursing model of care. Those have some interconnections, and then we see those get connected over, and we're going to talk more about the blue area, which is the MBI-HSS subscales. This is how we are measuring burnout. So there are 3 measures. Again, we're going to talk about this more, but there's the emotional exhaustion, depersonalization, and personal accomplishment. And then they linked those over to the purple area, which is the adverse patient outcomes. And I created those 4 extensions to this model, which is the pressure injuries, medication errors, falls, and infections. The model, it does provide a lot of insight within those interconnections. However, the point of my research was to expand those connections. I wanted to know more between the blue and the purple. I wanted to see what was exactly existing there. And then even furthermore, the purple, just the adverse patient outcomes and specifically fall rates. So my research question is very straightforward. What is the correlation between the 3 measures of burnout, which is emotional exhaustion, depersonalization, and personal accomplishment, and the prevalence of falls among patients living in a long-term care facility? My hypothesis 1 was emotional exhaustion will increase the frequency of patient falls. My second hypothesis was depersonalization will increase the frequency of patient falls. And we see for the third one, it's an opposite. So personal accomplishment will reduce the frequency of patient falls. So my methods, my participants, I did have some relationships just from my history of working, within the community here in southeastern Wisconsin. I was able to reach out, and I reached out to 6 total facilities, and I did get 3 of them at the end of it to agree to participate in my study. We did formal agreements with them, and my main contact was the directors of nursing. They were really influential in getting this research done and driving the response rate that I got from their nurses. I did go through IRB approval to make sure we were following all the ethical guidelines. I did only include RNs and LPNs for the study. I did not include any other professionals such as CNAs or your regular health aides. In order for them to participate, they had to have worked at least 1 shift in October of 2023 and scheduled to work 1 shift in November of 2023, which was my research time frame. So the data collection, again, was from October to November of 2023. The independent variables that I used for the study were those 3 subscales of the MBI, which is the emotional exhaustion, depersonalization, and personal accomplishment. The dependent variable was those patient fall rates. And when I was deciding on which variable to focus on, in that last slide, the 2 slides ago, we saw the nursing work-life model. I took into consideration all of those outcomes. However, I decided on fall rates because it's more accessible data for me to reference. As nursing directors, as facilities, we're tracking and monitoring that data, and it's very easy for a nursing director to pull that information for me as the researcher. The research tool that I used to survey the nurses on burnout was the MBI HSS MP, which we'll talk more in depth in the next slide. I did I did decide, in addition to that MBI, to grab some demographic information from my nurses, which is I wanted to know their gender, their licensure type, the hours that they're working per week, the shift they primarily worked on, the number of years they've been working in the healthcare industry. I also added in 3 additional work environment questions for them. I just wanted to get some extra data while I was sending these surveys out. So I did ask them, do they believe they have the necessary number of RN and LPN staff to provide the required patient care? They could answer agree, neutral, or disagree. And then I asked them, do you consider your work environment to be healthy? That was a yes or no question. And then the last question was how you would describe the quality of care being delivered on your unit, which could be excellent, good, neutral, fair, or poor. So this is the MBI HSS MP. I have outlined the specific questions, and you'll see that the numbers are a little different, like it doesn't go in direct order. That's because each question out of the 22 questions are aligned with the subscales. So the Burnout Inventory, the MBI, was published in 1981 by Christina Maslach as a standardized measurement tool that can capture a person's experience of burnout. Since its development, this tool has been administered to thousands of people who work in a variety of settings, and it is currently recognized as the leading tool for measuring burnout. There are 5 total versions. I used the version for medical professionals. That's the MP part of the abbreviation. This survey is really appropriate for nurses, physicians, health aides, and other medical professionals. Burnout is not measured as one total number. Some people think it's just, I have one measure of burnout. It's actually separate subscales, which is that emotional exhaustion, depersonalization, and personal accomplishment. Emotional exhaustion consists of 9 questions that we see over here that analyze the individual's feelings of being overextended and exhausted from the work they perform. A higher score indicates increased burnout. Then we move down to personal accomplishment, which is 8 questions. This analyzes the individual's feelings of competence and successful achievement within the work they are performing. This one is measured differently than the other 2, as a lower score would indicate that they are more burnt out, because you want to have more personal accomplishment, right? Depersonalization consists of 5 questions that analyze the individual's feelings of unfeeling and impersonal response towards the patients they are taking care of. Higher scores are indicating increased burnout. So let's talk about my research process. It's real, I just kind of want to generally go over how I did this. So once I got through my proposal, I met with the directors of the nursing facilities to really discuss how the survey distribution is going to look. I was able to so Mind Garden does manage the MBI through copywriting. So I did have to go and create the survey through them. They are able to personalize it, with those extra demographic questions and the 3 extra environment questions I wanted to ask. Which was great. And the way that these surveys go out is all electronic through email. It's just a link, which was very easy to use, similar to using like Qualtrics. It just was easier for the purpose of this to go through the copywriter of it, because they also gave me reports, which was really nice. IRB approval happened back in August of 23. I started my survey distribution right away on November 1st. I did finish my survey collection on the 30th. And then in the December 2023, I started getting the fall rates from the nursing directors. I will say for this research, the reason it was as successful in regards to, and we'll talk about how many responses I got, it really came down to that collaboration with these nursing directors. They were phenomenal to work with. They were excited about this research. They wanted their nurses to participate. So I can attribute a lot of the success to really that collaboration, and I am very grateful for them, and that they were able to help me push through as many surveys as we did and get the results that we did. So thank you to those nursing directors. I am eternally grateful for you. I do want to point out that for the surveys, all of this was no identifying data. I did not have access to the employees' names, their emails, nothing. I knew nothing. All that happened was the surveys went to the nursing directors and the nursing directors sent the link out to their staff, which was good for, ethical considerations. All right, so let's talk about the results. So for facility data summary, I exceeded my expectations for total response rate. An average online response rate is about 44.1%, and I had 74%, which was 45 out of my 62 nurses. Facility 1 has a bed capacity of 81 patients. There were 18 nurses there, and I had a 100% response rate. I unfortunately did have to exclude one nurse out of that data due to not meeting the requirement of working one shift in October and scheduled to work one shift in November. Facility 2 had a bed capacity of 100 patients. They had 25 nurses, and I had a 52% response rate, so 13 nurses responded. And then Facility 3 has 75 patient bed capacity. They had 19 nurses with a 74% response rate. 14 of them responded, but I did have to exclude one nurse out of that because on the first page of the survey that goes out, they did not consent to participating, so I had to take them out. Over on the right, I did put together a visualization of patient falls during October and November of 2023. I think it's good just to look at in general. So Facility 1 had 11 total patient falls. They also had 11 fallers, which means each patient had one fall. Facility 2 had 32 total falls, and they were the highest for fall rates. They also had 20 fallers, so there were some frequent fallers or individuals who did fall more than once in that facility. And then Facility 3 had 21 total falls and 18 total fallers, so not a very high rate of frequent falls, and it was in the middle for the total falls amongst the three facilities there. Burnout levels. So within the MBI manual, there is a summary of data that is provided to me that is from several large samples of completed surveys within the past 30 years. This was provided to me with the intent that researchers, that I as the researcher can utilize the data to show variability and reliability norms to compare my study to new populations. In Table 4.2, you will see a comparison of means and standard deviations between the study and the data provided within that MBI manual. I also wanted to include the strongest loading factor question for each subscale when I completed the factor analysis for all three subscales. So emotional exhaustion, we saw higher standard deviations, which show more variability. We saw a higher mean, and we also saw that the strongest loading question there was, I feel used up at the end of the workday. This is about an average score for burnout underneath the emotional exhaustion. The mean and standard deviation are consistent with previous studies as well. Moving into depersonalization, we saw a lower standard deviation here, which shows a little bit less variability. We also saw a lower mean. And the strongest loading question here was, I've become more callous towards people since I took this job. This is on the lower end of scores for burnout under depersonalization. And a potential reason for the lower score in my study could be related to why nurses choose their profession. So according to a study that I had read by LA et al. In 2012, individuals usually choose nursing as their profession either to care for others or because they believe it's their calling, right? We are nurses for a reason. We love caring for people. We're here to take care of you no matter what. The stereotype that nursing is a caring profession is largely supported by the fact that nurses are known for their willingness to care for others. And although we may feel emotionally exhausted from the work that we're doing, our primary nature is to still care for the patients. And that primary nature may outweigh any feelings of depersonalization that we are having. Moving on to personal accomplishment. So we saw a lower standard deviation here, which was showing less variability. We also saw a higher mean, which means they are less burnt out. And the strongest question here was, I feel exhilarated after working closely with my patients. This was about an average burnout score. And a potential reason for the higher mean in this study could be related to the years of experience the nurses have. My study specifically had about 58% of nurses reporting having worked in healthcare for more than 20 years. A study that I had read up on found that younger nurses with fewer working years had higher burnout scores. Older nurses with their rich life experiences and work skills may have a higher sense of personal accomplishment throughout their career. The nurse data, I do want to talk about, kind of those demographics that I got and kind of just go over what we found there. For comparison of the data, because you'll see some comparisons in here, I did pull the State of Wisconsin Nurse Survey Review. This is a survey that is required by the state of Wisconsin when a nurse goes online to renew their license every year. Even years is the RN and odd years is the LPN. This survey is mandatory. You cannot renew your license if you do not complete this. So the survey really collects a lot of good data related to their licensing, employment, demographics, education, work specialization, and income. So demographics. The majority of responding nurses in my study were female, 88.4%, which is significantly higher compared to the 47.34% within the state of Wisconsin. The majority of nurses who participated in the study also had an RN licensure, which was at 58.1% compared to the state of Wisconsin, which was 91.6%. We also saw that a significant number of the nurses who responded, which was 58.1%, reported having worked in healthcare for 20 or more years, which was lower than the state of Wisconsin's report of 63.16%. On the right, you can see the graph of the responses to the question of how many hours the nurses are working on average each week. The majority of our nurses are working between 34 to 40 hours, which is full-time, and we can see that is almost equal. We can also see that there's almost an equal number of nurses working less than part-time, so you're 32 hours or less, or they work overtime 45 to 60 hours, so 21 and 19% respectively. The next two graphs outline the responses to those healthy work-life environment questions I had asked and the adequate staffing for appropriate care delivery on their units. On the left, we see that a majority of the nurses did respond that they believe their work environment, in their perception, was healthy at 86%. On the right, we see that a majority of nurses also believe that there was adequate staffing on their unit for appropriate care delivery, with 67% stating yes, and then there was 19% who remained neutral on the question. All great outcome, all great responses. So, and then the last one here was what is the nurse's perception of the quality of care being delivered on the unit? 65% of the nurses did believe the quality of care was good on their unit, followed by 24% of them reporting that they believed it was excellent. Only 7% of the nurses were neutral, and then fair and poor were both at 2%. So again, really great responses to these questions. We're going to move into the MBI subscales and patient falls in regards to my hypothesis testing now. So for my first hypothesis, where we thought emotional exhaustion would increase the frequency of patient falls, there was no significant correlation here. The literature review for my study did find that nurses who experience emotional exhaustion are more likely to report poor or fair quality of care. It was also found that emotional exhaustion can be reduced when nurses have lower workloads. The nursing work-life model that I used for this study does outline a direct connection between staffing adequacy and emotional exhaustion, and it was interesting that for this study, most nurses, 68% of them, reported that they believed the staffing of RNs and LPNs on their unit was good. This could explain why there was no correlation between emotional exhaustion and falls. Emotional exhaustion can also be reduced when nurses are feeling more empowered and have greater freedom to perform their tasks. This study found that there was a higher mean for personal accomplishment, which could play a mediating role in my emotional exhaustion results. Moving on to the second hypothesis, we believed that depersonalization would increase the frequency of patient fall rates. We actually found a negative correlation, so we found the opposite of what I expected. Higher levels of depersonalization were found to be correlated with decreased patient fall rates. Previous studies have found that nurses who score higher in depersonalization are more likely to report poor or fair quality of care. Specifically, they are more likely to report incidents of falls. In this study, the majority of nurses reported that they felt the quality of care they provided was good at 65.1% or excellent at 23.3%. This could suggest that the hypothesis is mediated by the nurse's strong sense of duty to provide that excellent care to their patients. And finally, moving on to hypothesis 3, where we believe personal accomplishment will reduce the frequency of patient falls, we found a negative correlation here, which was, again, the opposite of what I had expected. We saw that higher levels of personal accomplishment were found to be correlated with increased patient fall rates. Previous studies have shown that nurses who score lower on personal accomplishment are more likely to report poor quality of care, including increased patient fall rates. Their personal accomplishment of nurses is indirectly impacted by emotional exhaustion and directly affected by depersonalization. So a better work environment is associated with better patient safety, and this study found that a majority of the nurses reported they felt their work environment was healthy at 86%, which means this could be a mediating factor within this hypothesis. Okay, and moving on to prediction models. So a few multiple regression models were completed for my study. We did run one for a predictor of falls. So the first one was for personal accomplishment and depersonalization in predicting fall rates together. This model was not found to be significant. It is important to mention again that separately, personal accomplishment and depersonalization do significantly predict falls. It's just when we put them together, they don't do it together. So then we'll move on to emotional exhaustion. So model 1, predictor of emotional exhaustion. We ran 3 total models for this. Model 1 saw that all of the work environment questions, depersonalization, and personal accomplishment were significant, with depersonalization being the strongest predictor variable here. Model 2 saw that adequate staffing, depersonalization, and personal accomplishment were significant, with staffing being the strongest predictor variable. And then model 3 was unique in surprising, because when we added in the work environment questions to this model, staffing was no longer a significant predicting variable. So it was interesting that all of these, everything was significant, but, and especially staffing was significant, which I think historically now have heard that staffing causes burnout. We don't have enough staff, I think it was really surprising that once you put in those work environment questions, though, into the predictor, staffing, it doesn't matter anymore. And then we did do a prediction model for depersonalization. The model with emotional exhaustion and falls predicting depersonalization was significant. So emotional exhaustion and falls, with emotional exhaustion being the strongest predictor variable in that model. So implications. We're going to move on to what we're going to do with all this, right? So this research really, like we kind of talked in the beginning, gave me the opportunity to analyze that objective patient data. There has not been a lot of research about that, where we're actually pulling those hard numbers, those fall rates, those infection rates, those pressure injury rates. So this really created a great environment to capture that information and talk about it and analyze it. So it also really highlights the multi-dimensional factors that really contribute, mediate, and result from burnout. Depersonalization and personal accomplishment are individually significant predictors of falls with medium and large effect sizes. The findings of this study suggest that nurses' perceptions of being overextended and exhausted in their workloads may lead to negative patient outcomes. And it really serves as a valuable resource for professionals and researchers who are continuing the work of analyzing burnout within the healthcare system. It underscores the need for that continued effort to address nursing burnout and its implications on patient safety outcomes. In theory, that nursing work-life model was created in 2006 to explain the connections between the nurse work environment, burnout, and patient outcomes. However, it was based on nurse perceptions. And while this model really provides a foundation for understanding burnout among nurses, there is still a need for further development and understanding of the exact interrelationships between the dimensions of the model. There is opportunity to expand this model's applications to other healthcare settings, as well as a majority of the settings that are influencing this model are hospital-based. I do suggest that there may be more mediating factors between the dimensions of the model, such as nurse perceptions, nurse resilience, nurse stress management abilities, the years of experience, and the motivation for providing care. And practice, while the results of my study did not really align with my initial hypothesis, it is still clear that burnout is a serious concern among nurses in long-term care. The literature review of this study identified that burnout has significant impacts on patient outcomes and safety, and it really is important for leaders to understand what causes burnout among their staff and take those steps to address it. Because once they have that deeper understanding of the factors that contribute to burnout, leaders can implement those good strategies that are going to support, engage, and retain your healthy nurses and staff. Conducting regular surveys, visit your patient care areas to observe those barriers and frustrations, create those opportunities for your staff to voice concerns. When I was working as a nursing director, I was out on the floor. I was rounding, I was talking with my staff. Tell me about your day. Tell me what's going on. Do you need help with something? Is a process not working for you? What can I do to help you? And creating that healthy environment to talk to your staff in a non-formal way. Like when you pull up a staff member into the office or in a staff meeting, they don't really, in my experience, they don't speak up as much, right? When you're having those informal conversations on the floor in the nursing environment, they're going to open up to you a little bit more, and you're going to be able to see too. I would always sometimes round and just stand back and watch how are they doing before I even ask them, what does it look like on the unit? Do they look stressed out? Are they running around? Are they flustered? What is going on with my nurses? Be involved with your staff. Ask those questions. They're going to feel that you care, and they're going to know that you care because you're trying and putting those efforts in. Another thing that nursing leaders can do is really take that initiative to build your knowledge base. Read articles, subscribe to blog sites, attend presentations, like this, workshops, reach out to other organizations, get your community together. I do know there is, in Wisconsin, when I was a DON, I was on the Wisconsin DON Council. Go to WALA, go to these conferences, attend these workshops, really get that understanding, because the more you can understand what the research is showing and what other people are experiencing and going through, the better you're going to be prepared to deal with it in your own facilities and your own day-to-day life. For nurses who are watching this, who aren't leaders, same concept. Get in there and read about it. You have support too, or bring it up to your nursing leader. Like, hey, this is what we can do for initiatives. Let's do more research into this. Let's talk about this more. Let's create a work group maybe about it, a support system. Really, this presentation and this research is not meant just for your nursing leaders. It's meant for all nurses so that you can understand what creates burnout and what factors into it, and just continue the discussions. If we don't talk about it, it's not going to get better. And even using there's online self-evaluation tools for leaders too, where you can kind of learn what areas you need to work on, like what is your leadership approach, how do you approach your staff, how do you interact with people. There's all sorts of tools that you guys can use to kind of analyze yourself as nurses and as leaders. And finally, if I haven't spoke about it enough yet in this slide, create a culture that values and respects your employees. There is nothing more, when we talk about values, when you're filling out, what are the values that you love most? For me, my best value as a leader that I love is having empathy and understanding of my staff. We are in some challenging times. COVID isn't as hot anymore. However, people are still dealing with struggles in their lives, and having just a little bit of empathy for our employees and trying to understand them. And I always assume the best intentions out of them until proven otherwise. Go into it with that mindset, because they're going to appreciate you even in difficult conversation or difficult situations. They're going to appreciate you having that empathy towards them more than anything else. Culture is huge for being a leader, and for nurses among nurses, treat each other with respect and empathy as well, because you don't know what someone else is going through. Be supportive. I think kind of leaning into that, you see so much on social media nowadays that is negative. It's just so much negativity, TikTok and these videos, and don't go into healthcare. Nursing is horrible. Like, I had a horrible shift. This is what I deal with. It's all negativity. I rarely see positive videos on TikTok of people talking good about being a nurse. And I think that needs to change. I think we need to change that perspective and just support each other again and come together to, at the end of the day, provide patient care. We are caregivers. We want our patients to be cared for and healthy. So that's my perspective on leadership and how you should go into your nursing day. Go into it with a good perspective and just support each other. And then let's kind of dive in just a little bit of future research, kind of what can be done, and even what I'm considering researching just a little bit more here. So the need to continue the research, obviously, from what I said, is needed, and we need to understand burnout from a variety of aspects, such as factors that contribute to its development. How is it mediated? How is it influenced? What are the negative effects of it? I think a more longitudinal research will help shed the light on that and how burnout develops and how it changes over time, and then kind of what the interventions are effective in preventing it and mitigating its negative outcomes. I do believe in the future, for us, for myself and for other researchers, doing more of collecting both that objective and subjective data would help, show just like a little bit more insight to it. So getting things such as like the nursing performance and success, it depends on multiple factors. There's more to it than just these simple MBI subscales. Like, there is more that goes into what our work environments are like and how we are successful as nurses. I do think that there also needs to be expansion into other disciplines, such as your certified nursing assistants, the allied health professionals, your patients receiving the care. I'd be curious to see what they have to say. And there also is really a potential for exploring a tool that better predicts burnout among nurses specifically, that can be applied across different health settings. While the MBI is well known and valid, it may not be the best tool to utilize for nursing staff. The MBI could be complemented with other tools that enhance and validate the measure of burnout among nursing staff. There are various tools that already exist for other job categories, such as physicians, teachers, psychologists, athletes, parents, educators. We as nurses should have a tool as well. So kind of looking into the future of that. And then finally here, I just really appreciate you guys taking the time to listen to me, to listen to what my research was, and kind of hopefully feel some of my compassion for it. And if there is anything you need, you have questions, insights, please reach out to me. This is my contact information. I am now done with school and working in the industry. I currently am working for Advocate Aurora Health. In the hospice sector. Hospice is something I hold very dear to my heart. So I have moved out of long-term care, but my years of working amongst the long-term care community is still very dear to my heart. And burnout exists in hospice too. So, and that's not talked about. So I am in a place where I am excited now to kind of move forward and continue talking about it. I did present back in March of 2024 at the Wisconsin Assisted Living Association conference and loved that. And they have invited me back again this September, I believe it's September, to speak again. So I want to do more conferences. I want to talk to more people about this. Try to pick out some of the good stuff from my research that is applicable for leaders and nurses, and just continue the discussions, like I said. So thank you again for listening to me. Please reach out with any questions, and I hope you guys have a wonderful rest of your day. Thank you so much.